The therapeutic landscape of ANCA-associated vasculitis has undergone a remarkable transformation over the years, from traditional cytotoxic agents like cyclophosphamide to targeted therapies. Such as Avacopan, treatment strategies have become more effective and safer. Understanding this evolution is essential for clinicians to make informed decisions, minimize treatment-related toxicity, and improve long-term outcomes for patients. It is a privilege to introduce Dr. Aflak Rasheed with FCPS qualifications in both medicine and rheumatology, along with MCPS in health professions education. He currently serves as Associate Professor and Head of the Department of Rheumatology and Immunology at Shaikh Zayed Federal Postgraduate Medical Institute, Lahore. His leadership and dedication to advancing rheumatology makes him an ideal speaker on this topic. Let's give a big round of applause for Dr. Aflak Rasheed.
Zainab, thank you very much for the introduction. And let's see, can we have my presentation? So I can recall in my previous nearly 22 years of rheumatology that the systemic sclerosis was once an orphan disease. SEM, madam and sir. And now we can modify the disease pattern. So with that, we today are going to have a newcomer for us in special disease, ANCA-associated vasculitis, and I'm going to highlight regarding what we have and how we are going to be changing in future regarding ANCA-associated vasculitis. Can I have my presentation? So I'm going to discuss about the layout of this presentation is I'm going to discuss a classification of ANCA-associated vasculitis with a little bit of pathophysiology so we can understand that where rituximab, where corticosteroids, where cyclophosphamide, and where this newcomer is getting its place. And along with that, I'm going to discuss a few trial history of this drug, which has been ongoing for the last 8 to 10 years. Okay, so layout would be like that. And we know that classification is very precise, and it is absolutely clear that granulomatosis with polyangiitis has a granuloma, and microscopic polyangiitis, there are no granulomas. And the thing which Professor Tafazzul discussed in the panel discussion that anti-proteinase 3 antibodies positivity is more related to granulomatosis with polyangiitis. Likewise, myeloperoxidase as well as anti-proteinase can occur in microscopic polyangiitis. The eosinophilic component is actually a separate animal. So I would like you to concentrate on this picture. It is an interesting picture. Don't be afraid that it is a difficult picture. Just concentrate that we have T cells and B cells, and we know that T cell and B cells combine to form activation of B cells, which later on causes makes ANCA antibodies. Likewise, neutrophils. These three agents, the culprits, starts to trigger. And what happens is that neutrophils, we know that cytoplasmic PR, perinuclear, and central antibodies are basically inside the cell, but they translocate over the cell membrane of the neutrophil, where B cell, T cell, which triggers the B cells, cause ANCA antibodies, and they combine and they further trigger chemoattraction with formation of neutrophil extracellular traps, which is going to be deposited in the vessel and cause intense inflammation, which causes activation of the complement system and cause C5a production, the complement alternate pathway activation leading to this all inflammation. Likewise, it also activates the dendritic cells, which in turn causes further B cells to activate and also helps in formation of the granulomas. So keep in mind this picture. So in epidemiology, pediatric age group doesn't have such incidence of this problem, but if it is around 11 to 14 years, and it is usually GPA form. Likewise, in adults, GPA is more common. It is more common than eGPA. Like it occurs in 50 to 70 years in GPA, MPA, and eGPA is 40 to 50 years. Likewise, slight male predominance for MPA and GPA, and female predominance for eGPA. Now, if we can see the incidence, I just want you to focus on this globe. This is GPA and this is MPA. As we go from west to east, whole of the scenario starts to change. This is GPA, blue is GPA, and as we go towards Japan, MPA is the most one. So we don't know what are the characteristics or genetics behind this. Perhaps someday we are going to identify. So for Pakistan, if we calculate the international or global population, we could have nearly over 4,000 cases per year of either GPA or MPA. So what are the key considerations in developing personalized vasculitis treatment? Number one, different vasculitis may share similar symptoms and treatment recommendations. Each disease is distinct and each patient is distinct, and one treatment may not work in a certain patient if it is working in the previous person. As well as there is a need of multidisciplinary approach. Rheumatologists along with nephrologists and dermatologists and pulmonologists are the integral part towards a successful treatment. And there must always be a shared decision for the patient, because the patient's goals, patient's preferences are the most important things. So there is an induction and there is a remission maintenance phases of the treatment, and regular treatment is required. Regular monitoring is required for its safety. Frequent follow-ups are required. Blood testing, imaging, and we need to check the medications for its side effects. Regarding management tools, we have guidelines. They are essential for us in planning a treatment. Expert tailor the plan to specific situation, and proactive participation of the patient is also very much important. So what happens is that in induction therapy, we divided the disease into non-severe and a severe organ-threatening disease. And glucocorticoids, rituximab and cyclophosphamide remains the mainstay of the induction and severe disease phase, while in non-severe disease, methotrexate and mycophenolate can be. Usually it is in the sinus disease. So targeted advanced therapies which we have now is rituximab, and recently in 2021, 5 years ago, Avacopan has been approved by FDA. So for maintenance therapy after induction therapy, we have rituximab, azathioprine, and methotrexate in non-renal cases. And what are the characteristics of specific autoantibodies? In the proteinase 3 ANCA, which is granulomatosis with polyangiitis, there is higher relapse risk, and rituximab is preferred. And in microscopic polyangiitis, there is more renal limited as well phenotype, and we have to individualize the maintenance duration. Likewise, we have safety snapshots as well. For rituximab, hypogammaglobulinemia, late onset neutropenia, and in cyclophosphamide, cytopenias, infertility risk, and malignancy risk. For Avacopan, liver enzymes elevation, and for glucocorticoids, its toxicity everybody knows. So, in treatment algorithm, we have a confirmed organ severity. We have to confirm the organ severity, initiate rituximab, cyclophosphamide-based induction, minimize glucocorticoids or no glucocorticoids and only Avacopan, and continue rituximab maintenance in high relapse risk patients. So, this previous slide was a summary of the guidelines, which I'm just going to touch briefly, that this is the BSR guidelines which have recently been published. And again, we have a life-threatening and no life-threatening disease and for which we have separate algorithms. But we can always skip glucocorticoids now. Here it is not available yet, but Avacopan is being used internationally and it has shown to be very superior to glucocorticoids in certain studies. Likewise, in severe disease with Avacopan as a steroid sparing, rest of the treatment remains the same, rituximab, cyclophosphamide, or combination of both if it is severe in nature. Likewise, ULAR in 2022 also updated, and it was again the similar picture. And lastly, the KDIGO guidelines, which were published 2 years ago, also gives us an insight that the consensus between the nephrologist and rheumatologist is there, except that regarding plasma exchange, there must be a fast raising renal compromise, as well as along with alveolar hemorrhage. And rituximab and cyclophosphamide combination in the treatments. So Avacopan is a selectively blocks 5A through a 5A receptor block. And how does it occur? This C5A is going to go to the neutrophil. In the next picture, I'm sure that there are also receptors for C5A here on the neutrophil, and it blocks and stops all the cascade in which it is going to cause endothelial injury and persistent inflammation. Well, this is the neutrophil, and there are receptors to C5A receptors, which triggers further inflammation and netosis, and this drug at this level stops it, while azathioprine, cyclophosphamide, and rituximab stops at the DNA level. So, how we get here? It has demonstrated effect on ANCA-associated vasculitis in phase 2 trials. Phase 2 trials, in phase 1 trials, just normal volunteers are given this drug and there are no side effects. Then in the phase 2 trials, it is given in the diseased patients in a small cohort. And in phase 3 trial, which is a larger trial, it is given and its effects are seen for a longer period of time, relatively longer period of time. So it's the first in class oral selective C5A receptor inhibitor designed to block C5A receptor. In mouse studies, it has been shown promising effects by inducing MPO, myeloperoxidase antibodies related ANCA-associated vasculitis. And likewise, I have just told you that currently they are enrolling phase 4 long-term 5-year trial in the community, and it is going to complete in 2028. So active patient selection considerations are very much important. Active disease requires steroid-sparing therapy, or when the patient requires it, difficulty in tolerating high-dose steroids, rapidly deteriorating kidney functions at presentation, and diffuse alveolar hemorrhages refractory to conventional therapy. It is not recommended in chronic liver disease or severe liver disease, and safety in pregnancy and breastfeeding is not known due to the fact that the data is not there. So before started, all the biologics, all the targeted synthetic DMARDs, LFTs, CBCs, and infection screen is necessary. And by calling and saying infectious screen, it is latent tuberculosis and hepatitis B and C infections. And vaccination should be there prior to its treatment. So, 3 guidelines to मैंने बता दी हैं. Can vasculitis, Canadian vasculitis also included this drug, and real-world studies between 22 and 25 have shown a reduced steroid exposure and improved quality of life, though concerns have been raised about liver injury. So what are the benefits of this drug? It is orally administered. It is a steroid-sparing, relatively well-tolerated, used in combination with standard therapy of rituximab or cyclophosphamide, and can improve even kidney functions. The cons are its cost, as we know that it is extremely expensive, potential liver toxicity. It is a 30 milligram twice daily dosage, and 1 capsule which comes in a 10 milligram formulation. So 3 capsules morning and 3 capsules evening. And we do not have a data beyond 1 year, because the study which was conducted upon which it was been approved lasted 1 year. So this was the study, the Advocate trial. I'm just going to give the salient features, not going to go into the details. So there were nearly 330 patients in an Avacopan arm and in the conventional control group. So what happened, there were the endpoints were interesting, that at 26 weeks, clinical remission, and then at 52 weeks, that remission must be there. In Avacopan, after induction, Avacopan was started and given for 52 weeks, and for this segment, control arm, glucocorticoids were given, and they were tapered in 20 weeks to minimum dose of 5 milligram per day. And which patients were included? Newly diagnosed, relapsed patients having diagnosis of GPA 181 and MPA 149 with these antibodies profile, renal elements involvement, then rituximab was given in 214 patients, and oral IV or oral cyclophosphamide in 116 patients. There were 2 endpoints which I've just discussed, that at 26 weeks and at 52 weeks. And usually it was considered that the Birmingham vasculitis activity score should be 0. It is 0 to 63, and mean score in these patients when enrolled was nearly 13 to 16. And the endpoint was remission at 26 was 0, and no glucocorticoids for this disease in previous 4 weeks, and then sustained remission at 52 weeks. Secondary were the glucocorticoid-related attributes, including time to relapse to vasculitis, change in kidney functions, health-related quality of life, and safety and adverse effects. And at week 26, it was evident that Avacopan was non-inferior to prednisolone, and it was superior at 52 weeks. And we can see that this is the 26th week when active control arm, there was a 70.1, and this was 72.3, nearly no difference. So it was not inferior to causing relapse. And at 52 weeks, it even extends as compared to the conventional arm. So Avacopan arm improved the renal function, and it even improved the creatinine clearance at week 26, and at week 52 more than that. So what about this drug's safety profile? Because it is again a drug can cause this whole bunch of side effects. But in March end, there was a drug safety communication to the manufacturer. by FDA. And what they say that they have found some fallacies in 9 of the 331 patients in Advocate trial, and they have asked them to reconsider their endpoints. As well as hepatotoxicity was also mentioned as a concern. On 28th January, the manufacturer denies that they are not aware of any of these 9 patients having some endpoint fallacies, and they are not going to withdraw the drug. And as it is, its risk is far less than the benefits. And what FDA depicted? FDA identified 76 cases of drug-induced liver injury with reasonable evidence of causal association with Avacopan, out of which there were 54 hospitalizations and 8 deaths. And out of 76, 60 cases of initial liver injury, which improved later on, and most cases out of 76, 66 were from Japan. There was a study I was reading that why Japanese people have a good effect of methotrexate low dose as compared to European people. So there were certain genetic attributes which lead to a low dose increased levels of methotrexate for the rheumatoid arthritis patient as compared to the European population. So it can be something like that of an attribute causing this problem. The median time of onset of this injury was 46 days from the time of start, and out of 76 cases, 7 reported biopsy-confirmed vanishing bile duct syndrome, which is a lethal disease, and 6 died from Japan and 1 from Canada. 3 of them were fatal. So what FDA recommended? FDA again recommended, like it has recommended for rest of the biologics and the disease-modified drugs, and that is LFTs every 2 weeks while starting in the first month, then monthly for the next 5 months, and then as clinically indicated. And we have to stop Avacopan if ALT or AST is more than 3 times the upper normal limit, or ALP is more than 2 times, or there are symptoms which leads towards a cholestasis, jaundice, or pruritus. And if liver test abnormalities or symptoms of liver injury do not improve, patient should be referred to a hepatologist. So in conclusion, the FDA said that DLA associated with Avacopan predominantly reported in Japanese population. FDA is continuously monitoring the patients on Avacopan, monitor patients of adverse reactions, especially in the first 2 months. So the last slide. ANCA-associated is an aggressive disease. New insights in pathophysiology directs towards targeted therapy as we have Avacopan now. And treatment guidelines are rapidly evolving, including new options like this one. And steroid sparing have emerged as promising alternatives, and safety profile will be established as upcoming data is analyzed. And careful in decision making and monitoring is pivotal by us, by the rheumatologist or the treating physicians. Thank you.